I'm Colin Dayan. I'm Head of Clinical Research and a reader in medicine at the Henry Wellcome Laboratories for Integrative Neuroscience and Endocrinology at the University of Bristol. This is the second lecture in the endocrine series, and we'll be covering diseases of the thyroid and also of calcium homeostasis. So here's the first question. A 42-year-old woman presents with a mass in her neck and symptoms of choking and shortness of breath when she lies down. Past history of note includes a family history of goiter, for which her mother and grandmother both endured partial thyroid resection. You examine her and suspect she does have a multinodular goiter. And here are the investigations. Of note here is a normal TSH. You suspect that she may have a retrosternal thyroid extension. Which of the following will be the investigation of choice for this patient to determine the degree of retrosternal involvement? And here are your 5 options. So the preferred option is a CT of the chest. Many of the other options would image the thyroid gland. For example, if we look at the bottom, a radioisotope scan would show uptake into the thyroid gland. It's sometimes helpful in showing the activity of the thyroid gland, but is not the best way of defining the anatomy. A thyroid ultrasound would also show the size of the thyroid gland, but it wouldn't show the relationship to the thoracic inlet. Older investigations, such as a chest X-ray, might show enlargement of the upper mediastinum, but which would not be very accurate. And an X-ray of the thoracic inlet was what we used to do before CT scans. CT, however, would show you not only the size of the thyroid gland, but exactly the relations in relation to the thoracic inlet. So that's the preferred investigation of choice. Let's just quickly review goiter. So goiter just means an enlarged thyroid gland. And it's important when you're thinking about this to think about the endocrinology as well as the size of the gland. So is the patient hyperthyroid in tests, in which case we're talking about a multinodular gland normally, or possibly if it's a smooth enlargement, Graves' disease? Is the patient hypothyroid, in which case the usual diagnosis is Hashimoto's disease, though there are 2 other options there. Iodine deficiency is unusual in the UK to cause large thyroid enlargement. But most commonly the patient is euthyroid with a multinodular gland, so it can be euthyroid or thyrotoxic, and Hashimoto's disease can cause an enlarged gland, but not usually so much so that you get retrosternal extension. And there are other causes listed there of a euthyroid enlargement of the thyroid gland or goiter. Question 2. A 45-year-old woman presents to the clinic complaining of a lump in the neck, which becomes particularly prominent when she swallows. On examination, there's a thyroid nodule at the base of the neck. Leukocyte screening of 2 other family members who suffered thyroid carcinoma has revealed the RET proto-oncogene. Which type of thyroid carcinoma is linked to the RET proto-oncogene? And here are your 5 options to consider. So the correct answer here is medullary thyroid carcinoma. The RET proto-oncogene is abnormal in multiple endocrine neoplasia type 2, which is associated with medullary thyroid cancer and also with hypercalcemia and pheochromocytoma. But it's also abnormal in familial medullary thyroid cancer. How can you remember that? The point to remember is that medullary thyroid cancer is the odd one out of thyroid cancers. And it arises from the C cells, not the thyrocytes, the calcitonin-making cells of the thyroid gland. So it's very different from the rest of the thyroid gland and thyroid cancers. And it arises from the C cells, not the thyrocytes, the calcitonin-making cells of the thyroid gland. So it's very different from the rest of the thyroid gland and thyroid cancers. Let's think a little bit about thyroid nodules. So if somebody does have a nodule, as this individual does in the neck, again, we want to know the endocrine status. And if the endocrine status is abnormal, focus on the endocrine status and don't worry too much about the nodule. So if it's hyperthyroid, we're going to treat a toxic nodule. If the patient is hypothyroid, it's probably Hashimoto's disease and we can give thyroid hormone replacement. It's only when it's euthyroid that I would recommend referral to a surgeon who specializes in this area, and the next investigation is usually the fine needle aspiration, because we're looking here for a malignancy. Now, only 5 to 10% will be malignant, and the majority will be benign. If there is a malignancy, In general, thyroid cancer is the best malignancy to have, if that can be said, because the commonest malignancies are papillary and follicular thyroid cancer. These are thyroid cancers arising from thyroid cells, and they're well differentiated, so they're called differentiated thyroid cancer. Being differentiated is generally a good sign, and in fact the prognosis is excellent for both of these, papillary being better than follicular, so I've listed papillary at the top there. There is a third type of cancer that arises from thyroid cells, anaplastic thyroid cancer, which has an extremely poor prognosis, and people rarely survive a year. It doesn't present as a nodule, but a diffuse enlargement somewhere in the neck because it's enlarging so rapidly. What can present as a nodule, as in this question, is medullary thyroid cancer. As we've said, it arises from the C cells, so it's the only one that secretes calcitonin, and that can occasionally cause diarrhea. Importantly, it may be familial and associated with MEN2, and it can be picked up by genetic screening when it's familial. And in fact, this is one of the very first cancers in which the genetic abnormality can result in recommendation for a thyroidectomy and preventing this unpleasant cancer, which is often a cause of death. And in the families that are affected, typically thyroidectomy is done at the age of 2 or at the age of 5 years old, removing a normal thyroid gland because there's such a high confidence that these people are going to develop thyroid cancer. Question 3. A 35-year-old man comes to the clinic complaining of tiredness, lethargy, and an increasingly hoarse voice. He also tells he's been losing hair over the past few months and has noticed fullness in the neck. And he's gained 7 kilos in the last 3 months. On examination, he has a puffy face and periorbital edema, and there is a firm rubbery goiter. His pulse is slow at 48 per minute and regular, and his blood pressure is 142/73. Here are the investigations. And you'll notice they've given us a raised TSH level there, the normal level between 0.4 and 4. The cholesterol level is also quite raised. And they've given us something else to do with the thyroid, an FNA, or fine needle aspiration result, diffuse lymphocytic and plasma cell infiltration. Which of the following is the most likely diagnosis? And here are your 5 options to consider. So the best answer here is Hashimoto's thyroiditis. Well, let's start with B, atrophic thyroiditis or atrophic hypothyroidism. Well, that means that the gland would be atrophic, and this isn't atrophic. There's an enlargement in the neck, so that seems unlikely. Graves' disease is typically associated with hyperthyroidism, so that seems unlikely. De Quervain's thyroiditis is usually associated, initially at least, with hyperthyroidism and often with pain or discomfort in the neck, which is not what's being described here. It also has giant cells on fine needle aspiration and not lymphocytes. So that leaves us with Hashimoto's disease and thyroid lymphoma. And I would group those two together. It can be extremely difficult on an FNA to tell the difference between the two. And thyroid lymphoma is rare, but it arises from Hashimoto's disease. So with all that lymphocytic infiltration that you get in Hashimoto's disease, presumably 1 or 2 of the lymphocytes then develop mutations and go on to become a lymphoma. So almost every thyroid lymphoma is on a background of Hashimoto's thyroiditis. In this context, they are not describing abnormal lymphocytes. There was no suggestion that there was a lymphoma present, and that's why they've gone for the diagnosis Hashimoto's thyroiditis when there was a very high infiltration with lymphocytes into the thyroid gland. Question 4. A 27-year-old pharmacist is admitted to the emergency room with a panic attack. On further questioning, it transpires that she's been suffering from palpitations and has lost weight over the past 6 months. Her period stopped 3 months ago. On examination, her blood pressure is 145/90, pulse is 92 per minute at rest, and she's slim with a BMI of 20. The remainder of her clinical examination, however, is unremarkable. Here are her investigations. And you'll see a low TSH now. The free T4 level, they haven't given you the reference range, but the typical reference range is 10 to 25, so this is a raised T4. There is a low thyroglobulin level and decreased thyroid uptake on scintigraphy. The question is, which of the following is the most likely diagnosis? And here are your 5 options: Hashimoto's thyroiditis, Graves' disease, toxic multinodular goiter, thyrotoxicosis factitia, or struma ovarii. The answer we're looking for here is actually thyrotoxicosis factitia. We need to work through the tests to understand why that is. And I'll just go back to show you the test results again. So firstly, we need to decide whether this woman has hyperthyroidism. Is there a high level of thyroid hormone? And in that situation, you need to see a low TSH in combination with a raised T3 or T4. And we have that. So it looks like we have primary hyperthyroidism. Primary meaning it's coming from the thyroid gland. Secondary hyperthyroidism is extremely rare from a TSH secreting tumor, and then you would have a normal TSH with a raised free T4. But this is the typical pattern. So we're comfortable, both tests are pointing in the same direction. She has a high level of circulating thyroid hormones. So now the question is, where is it coming from? If it's coming from the thyroid gland, we would expect to see increased uptake of radioactive tracer, so that's usually technetium-99, but you can use radioiodine as well, into the gland, because it would imply that they're taking up iodine into the gland and making thyroid hormone. So rather surprisingly, there's a decreased thyroid uptake. And that makes you wonder where the thyroid hormone is coming from. And it could be that it's coming from an ectopic source, that's struma ovarii, meaning a bit of ovarian tissue that's changed into thyroid tissue as making thyroid hormone. So then the uptake would be in the ovary rather than in the thyroid. It could be that there has been discharge of thyroid hormone from the gland. So in a thyroiditis, an inflammatory thyroiditis, you do get decreased uptake as well, because what's happened is the stores have been released. You're not making new thyroid hormone. And eventually those stores wear out after 2 or 3 months and you become actually hypothyroid. So that would fit with a decreased uptake. But what about the low thyroglobulin? Thyroglobulin is confusing, but it is the storage hormone for thyroid hormone. So when it's synthesized, it binds to the protein thyroglobulin, and it's stored in that colloid in the middle of thyroid tissue as a store of thyroid hormone. If you're making thyroid hormone, and if you're over-making thyroid hormone, you should have present or increased levels of thyroglobulin, because you release some of the protein at the same time as releasing the thyroid hormone. So the level is low, suggesting again that it's not coming from the thyroid gland. So let's look at the possible causes again. We think it's not B, Graves' disease, because there wasn't increased activity in the thyroid gland. There wasn't increased uptake on scintigraphy, and there was a low level of thyroglobulin. Hashimoto's thyroiditis is typically associated not with thyrotoxicosis, but with hypothyroidism. Occasionally, transiently, you get thyrotoxicosis at the beginning, but that would seem unlikely, and again, it's production from the thyroid gland. A toxic multinodular goiter would also involve production from the thyroid gland, and that's not what we see here. Struma ovarii is potentially a possibility here, as is the option that she's taking thyroid hormone. And if she's taking thyroid hormone, there would be suppression of thyroglobulin, because now there's no activity anywhere of thyroid hormone synthesis. Struma ovarii, you might expect to have some thyroglobulin release because there's some thyroid-like tissue from the ovary. And of course, she's a pharmacist, which we always need to bear in mind in those questions, suggesting that she has access to thyroid hormone, and she's abusing thyroid hormone here in order to achieve weight gain, which is the commonest cause. So this is an unusual cause, but it emphasizes the tests that we need to do to diagnose thyrotoxicosis and the cause of it. So if we review the causes of thyrotoxicosis, there are 3 main causes. Graves' disease, which is 60 to 70% of all thyrotoxicosis. And the absolute clue to Graves' disease is thyroid eye disease. And thyroid eye disease means proptosis, that's poppy eyes, and it also means diplopia or periorbital edema. And you could have any of those features separate from each other. So often people think if you don't have proptosis and have diplopia, that can't be thyroid eye disease. I would point out that lid retraction and lid lag are just manifestations of high thyroid hormone levels. So this lady could have lid retraction and lid lag because she's eating thyroid hormone, but she would not have proptosis. There's nothing pushing the eyeball forward. She wouldn't have diplopia, and she wouldn't have periorbital edema. If those features are present, you're confident without any other investigations that this is Graves' disease. But it's not always present in Graves' disease. In about 20 to 30% of cases, particularly in the elderly, it's toxic multinodular goiter, which is a multinodular goiter that over the years has become autonomous and is not due to an autoimmune cause, or a single nodule, toxic nodule. And then we have the rarer causes, thyroiditis associated with low uptake, that's discharge of thyroid hormone from the gland, which could be post-viral, subacute, also called de Quervain's thyroiditis, associated with pain in the neck and a raised ESR. In individuals that do have autoimmunity, they occasion discharge from the gland thyroid hormone stores, and that's called lymphocytic thyroiditis, with a transient thyrotoxicosis and then hypothyroidism pattern. And in people with autoimmunity, when they go through pregnancy, after the pregnancy, it's very common for them to have a transient thyroiditis, discharging thyroid hormone stores, so they get an increase in thyroid hormone level followed by hypothyroidism. That's postpartum thyroiditis, which is usually asymptomatic. Amiodarone, because of the high iodine load, can be associated with thyrotoxicosis and a very refractory form of thyrotoxicosis to treat. And iodine itself, such as in contrast media for imaging, can trigger thyrotoxicosis, particularly if you have a multinodular goiter to begin with. And as we've seen, there's rare causes such as thyroxine ingestion. Neonatal thyrotoxicosis is in the offspring of women with Graves' disease and is due to the antibody that stimulates the thyroid gland in that situation, the TSH receptor stimulating antibody crossing the placenta into the baby. It's going to be transient because after several weeks, the maternal immunoglobulins are gone from the baby and eventually they will return to normal thyroid function. In terms of causes of hypothyroidism, which was not present in this case, the vast majority is caused by autoimmune thyroiditis, Hashimoto's disease, in iodine-sufficient countries such as the UK. Other causes are treatment for thyrotoxicosis, and in fact, 1/3 of all the people on thyroxine have either had a thyroidectomy for some reason, either thyroid cancer or thyrotoxicosis, or radioiodine to ablate a thyroid gland. Hopefully you pick that up in the medical history. Rarely it's secondary to pituitary disease, and in that situation the TSH is not raised, and that can be misleading because if you don't do a T4 or request the lab to do a T4, you won't pick it up. And there are drugs that can cause hypothyroidism. Amiodarone, we mentioned before, can cause both thyrotoxicosis and hypothyroidism. Lithium can cause both. Carbimazole clearly is used for treating thyrotoxicosis and causes hypothyroidism. And the interferons cause inflammation in the thyroid gland and can trigger hypothyroidism, particularly in patients who had pre-existing autoimmunity, Hashimoto's disease. And we see that in people being treated, for example, for hepatitis. There is congenital hypothyroidism, and as you will know, there is routine testing of babies for this, and that's usually where there's a defect in one of the enzymes or molecules involved in thyroid hormone synthesis, or that there's maldevelopment of the thyroid hormone, that it's not present, it's ectopic, and so results in hypothyroidism. And very important to pick up at birth, otherwise cretinism will develop where there's impaired neurological development of the child. Worldwide, the commonest cause of hypothyroidism is iodine deficiency, and that's commonest in mountainous areas such as in the Andes, but also in some parts of Europe, for example, southern Germany. Question 5. A 38-year-old woman presents to her GP complaining of palpitations, sweating, and weight loss of 4 kilograms over the last 6 months. She has a history of thyroid disease in the family, and on examination she has a blood pressure of 145/85 and a tachycardia at 92 per minute. Here are her test results. Of note is a low TSH level. You suspect that she has thyrotoxicosis. Which of the following fits best with the actions and effects of thyroxine? You were hoping this was a more straightforward question than it turns out to be. So here's the 5 options for this question. And the correct answer is improved insulin sensitivity. What we're looking at here is the actions of thyroid hormone. Let's work our way through. So if we start at the bottom, increased bone mass. Well, high levels of thyroid hormone, thyrotoxicosis, is associated with osteoporosis. In fact, there's very little that causes increase in bone mass, and certainly hypothyroidism doesn't increase your bone mass. And thyrotoxicosis definitely does not. It results in the opposite. So we can rule out E. Increased prolactin release. Now, what they're getting at there is hypothyroidism. As in, people with hypothyroidism, they have a high TRH from the hypothalamus, causing a raised TSH in the pituitary. And TRH actually stimulates prolactin release. So in hypothyroidism, we get a raised prolactin level, but not in thyrotoxicosis as we have here. Increased tissue elasticity, and that's not typically a feature of thyroid increase or thyrotoxicosis. Decreased myocardial oxygen demand, well, thyrotoxicosis increases activity, increases metabolism, it increases the heart rate and increases myocardial oxygen demand. So that one's not correct either. And in fact, it does result in improved insulin sensitivity. And certainly I had a patient with type 2 diabetes who found he needed less and less insulin and lost weight. He was very pleased with this, only to discover that he had thyrotoxicosis. So we need to think about the unusual features of thyrotoxicosis, and you'll be familiar with the common features: weight loss, palpitations, particularly atrial fibrillation, heat intolerance, and tremor. But it's important to be aware of the slightly less well-known manifestations. Proximal muscle weakness, particularly in young women, is quite striking. And in fact, if you ask them to come down, to kneel down with you, they'll often have to climb up a chair or a desk in order to get upright, because they can't actually lift themselves up with their proximal muscles. Quite striking, and nothing you'd expect from a 20 or 30-year-old. It's almost a Gower's maneuver as described in children. Amenorrhea is certainly associated, partly due to the weight loss and partly a direct effect of thyrotoxicosis. And it's important to realize that it's a cause of raised alkaline phosphatase, and this is from both liver and bone. So it's an effect of thyroid hormones on the liver, but also an effect on the osteoblasts. We mentioned the increased myocardial drive and the thyrotoxicosis, and in this condition there is in fact a risk of high output heart failure, so driving the heart so fast that you could develop heart failure. Rarely, it is a cause of hypercalcemia, which disappears once you treat the thyrotoxicosis, and again that's a direct effect of thyroid hormone on the osteoblasts. And gynecomastia. This is an effect, again, of thyroid hormone on estrogen metabolism. There are also unusual features of hypothyroidism. You'll be aware of weight gain, feeling cold, dry skin, constipation, and enlarged red cells. But it's important to be aware of a raised prolactin. We just mentioned that before, and that can cause galactorrhea. So it's an important, easily treatable cause of galactorrhea and a raised prolactin. It can actually result in heavy periods, menorrhagia, rather than amenorrhea, and is a cause of a raised cholesterol. It also has neurological effects, such as deafness and ataxia, confusion, and you'll have heard of myxedema coma, where if people are hypothyroid for many months, untreated, particularly in the elderly, it can be a cause of unconsciousness and coma, which is difficult to treat, but does respond to thyroid hormone replacement. Question 6. A 30-year-old woman presents with an 18-month history of polyuria and polydipsia. Her only other history of note was increasing joint pains and one visit to the GP with depression some 6 months ago. Examination was unremarkable, and here are her tests. You'll be thinking about causes of polydipsia, polyuria. You might be looking for here a raised glucose level, but that reassures you this is not diabetes. And it can happen in renal failure, but we've got normal renal function. So you'll have noticed the raised serum calcium at 3.1 and a serum phosphate, which is actually at the lower limit of normal, and a parathyroid hormone level, which is very slightly raised. Which of the following is the most likely cause of this clinical picture? And here are your 5 options. So the correct answer here is primary hyperparathyroidism. Why is that the case? Well, we have a normal or slightly raised PTH, parathyroid hormone level, in the presence of a raised calcium. And that's not normal. Normally, if the calcium was high, the PTH should be suppressed. So that tells you that PTH is driving the high calcium. And that tells you that you've got hyperparathyroidism. If we look at the other options here, a raised level of calcitonin, well, calcitonin actually lowers calcium levels. In fact, even in medullary thyroid cancer, when you've got high calcium levels, strangely enough, it really has very little effect on calcium levels. Although we do occasionally give calcitonin, salmon calcitonin, as a way of reducing calcium. Certainly in this context, it wouldn't be associated with hypercalcemia. What about hypervitaminosis D, so high levels of vitamin D? Well, vitamin D causes an increase in both calcium and phosphate, because its main action is to increase absorption from the gut. It, if you like, regulates the chronic supply, the long-term supply of calcium to the body by regulating gut function. But remember that calcium and phosphate move together with vitamin D. So if the vitamin D level is low, you get a low calcium and a low phosphate. And if vitamin D levels were over-replaced, you get a high calcium and a high phosphate. And in this individual, we had a high calcium but a low phosphate. And that's very characteristic of the action of PTH, which is not so interested in the gut. It's interested in regulating the calcium minute to minute. And it does that by mobilizing calcium from bone, so you get a release of calcium, and at the same time, it results in secretion of phosphate from the kidney, so you get a low phosphate. Could it be secondary hyperparathyroidism? Well, secondary hyperparathyroidism is where you have a low vitamin D level, and the PTH is trying to compensate for this. And if that happens, the calcium level is actually low. You do have a high PTH level, but trying to compensate for the low calcium. So you would only see this picture when you've got a raised PTH with a low calcium level, and that's not what you see here. If that goes on for a long time, you can develop tertiary hyperparathyroidism, where the parathyroid glands now become autonomous. And then you could get the picture of a raised calcium and a raised PTH together. In that situation, there's usually a cause, as we'll see in a minute, for why you had a low calcium in the first place driving the PTH overproduction. What about medullary thyroid carcinoma? Well, we've said it can produce calcitonin, which really doesn't affect calcium levels, although you might think it might. And if it had any effect, it would lower calcium levels. So that's why we've ended up with primary hyperparathyroidism. We need to think a little bit about how you'd investigate a high calcium level, which is quite commonly found on routine biochemical investigation. So we're typically talking about a calcium level of more than 2.7 millimoles per litre that's present on multiple testing, on repeat testing. If this is present, the next step is to measure a sensitive PTH, so an accurate PTH assay. And most of the labs now will do a sensitive PTH assay, but it must be done when the calcium is raised, because you can't say it's abnormal if the calcium is back to normal. So we noticed here that a PTH level in the normal range in the presence of a high calcium is abnormal. If the PTH is raised or normal in the presence of a high calcium, we've got hyperparathyroidism. And then the two options, as we mentioned, are primary or tertiary. And it's only going to be tertiary if we can find a reason for tertiary, meaning that we've got vitamin D deficiency usually, or renal failure. So the next test that we would do in association with that, we would check for urinary calcium creatinine ratio, because there's a rare condition called familial benign hypocalciuric hypercalcemia. And this is where the four parathyroid glands become overactive due to an effect on calcium sensing, a gene defect on calcium sensing. And that's important to know, because all four parathyroid glands will be overactive, and in general it doesn't need to be treated, which is why it's called benign. It's very rare and it's familial. We would also look for kidney stones, and we would look for problems with renal function there as well. Because if it's going to be tertiary, that's driven usually by vitamin D deficiency or by renal insufficiency, renal failure. But by far the most common cause is hyperparathyroidism of primary origin. If, however, the PTH is low, the thing we really need to exclude is malignancy. So that may be metastatic malignancy to the skeleton, or it could be secretion of PTH-related protein. And it's important to emphasize that PTH-related protein is not picked up on a PTH assay. There's some confusion sometimes around that, but the PTH will be low because it's not detecting that hormone released from the metastases or from the primary malignancy that is causing a PTH-like action. Myeloma is also another important cause of hypercalcemia. If that is not the case and you find no evidence of malignancy, you're into the small print here, and there's a list there of rarer causes of hypercalcemia. Question 7. A 65-year-old woman was known to have chronic low back pain and noticed a severe sharp pain in the left groin after a minor fall and is unable to walk. The left neck of femur fracture is identified on radiological examination. Routine laboratory evaluation discloses a serum calcium that is low at 1.9 millimoles per litre, a serum phosphate concentration of 0.68, and an increased serum alkaline phosphatase activity. The serum parathyroid hormone level was subsequently found to be elevated. The most likely diagnosis is, and here are your 5 options to consider. And the correct answer here is vitamin D deficiency or insufficiency. Why is that the case? Well, we mentioned before that vitamin D affects calcium and phosphate together. Here we're seeing a low calcium and a low phosphate. And that would mean it would be unlikely to be due to a lack of parathyroid hormone. A is not correct because primary hyperparathyroidism would cause a raised calcium. But if they'd slipped in there hypoparathyroidism, that wouldn't be correct either because you'd see a raised phosphate with a low calcium. Hypervitaminosis D is clearly not correct because that would cause a high calcium and a high phosphate. Paget's disease of bone generally does not affect calcium levels, except possibly following a fracture when you can get a raised calcium. And osteoporosis is not associated with a disturbance in calcium metabolism. So that leads us to the vitamin D deficiency. Diagnosing hypercalcemia is important, and there are really only 2 major causes. So firstly, we need to be sure that the calcium level is low, and very frequently we see slightly low calcium levels due to abnormalities in albumin or levels that on repeat testing are really within the reference range. So it needs to be consistently low. We need to be sure that the albumin or the corrected calcium doesn't explain the low calcium. Then we're interested in the phosphate. We're interested in creatinine because renal function is going to affect your calcium level. And we're very interested in the alkaline phosphatase. Important to test the magnesium early because a low magnesium drags down the calcium and actually impairs PTH secretion and action. So a low calcium could be due to a low magnesium level. That's an easy thing to rule out early on. And we'll want to know the PTH, but when the calcium is low, we'll want to know how the PTH is responding. So if there's a low magnesium level, as you see in the second box, well, we'll replace that. If there's a low albumin, it can be confusing what the actual calcium level is. We might need an ionized calcium to work out whether it really is low or not. Assuming it is low, if we, as in the box on the left-hand side, we've got a raised alkaline phosphatase and a raised PTH, clearly the PTH is not the cause of the low calcium because PTH causes a raised calcium. It's a secondary effect. This is secondary hyperparathyroidism, and it's due to a lack of vitamin D deficiency or impaired action. You get a raised alkaline phosphatase because of the effects on osteoblast and osteoclast function, particularly osteoblast function. If the PTH level is normal, as in the right-hand box, or low, that's inappropriate with a low calcium. The PTH should be responding. And then we'll point the finger at PTH to say that's where the problem lies. The alkaline phosphatase will be normal in this context, and now we're dealing with hypoparathyroidism. And you'll remember that that would be associated with a low calcium but a high phosphate level. Occasionally you see a raised PTH but a normal alkaline phosphatase, and this is because of resistance to the action of PTH. PTH now is the problem, but it's not acting. It's not that it's not secreted, it's not acting. And that is pseudo-hypoparathyroidism, and that's associated often with phenotypic abnormalities, typically a short fourth metacarpal, short stature, and sometimes with mental impairment. Important to think about causes of vitamin D deficiency. Unfortunately, I would say, we're now measuring vitamin D very frequently in the population, and most general physicians and GPs are not sure how to respond, largely because we don't get much sun exposure. Vitamin D levels in the population overall are low. Common causes are either dietary or sun exposure deficiency, and that's going to be particularly an issue in vegans who have little dairy product intake, and they may be from the Asian subcontinent, which means that they have a darker skin and so cannot respond to the very low levels of sunlight that we get in the UK, and often are more covered in their clothing, so they get less exposure, tend not to do sunbathing. So it's both dietary and sunlight exposure. Important other causes, though, are malabsorption. It's very important to think about occult causes of malabsorption because it's a diagnosis you want to make. For example, celiac disease, but if we know them to have Crohn's disease or a section of the ileum, that may be a cause as well. And then renal failure. And renal failure causes a low level of vitamin D because of the activation of vitamin D. There is vitamin D present, but we're not getting 1 hydroxylation of the vitamin D. 25 hydroxylation, if you remember, happens in the liver. That's the first step. And then you need 1 hydroxylation to make 125 vitamin D to make fully active vitamin D. And the 1 hydroxylation happens in the kidney. So in the presence of renal failure, we get impaired action of vitamin D because it's not appropriately activated. And we get low calcium, we get secondary hyperparathyroidism. And rare congenital defects are congenital 1-hydroxylase deficiency and a vitamin D receptor defect. And these are called vitamin D dependent rickets, strangely enough, type 1 and type 2. The strange term vitamin D resistant rickets actually refers to phosphate leak, so low levels of phosphate, which can also give you osteomalacia. Not a true vitamin D deficiency. And that concludes our lecture covering thyroid and calcium abnormalities.